Welcome back. Whether you are a dedicated medical student deep in your exam prep right now, or a junior doctor refining those medico-legal principles.
Or even a senior clinician, brushing up on your forensic foundations.
Exactly. Wherever you are in your training, you are in the right place. Today, we are examining a physiological baseline so fundamental that its disruption leaves signs ranging from the catastrophic to the nearly imperceptible.
Which is what makes it so challenging.
Right. We are talking about breathing. It's an instinctive mechanism. But when it's obstructed, when we look at mechanical asphyxia, the resulting forensic signs can carry profound, sometimes life or death, medico-legal weight.
They absolutely do. And because of the legal and clinical weight these findings carry, our discipline really demands extreme precision in how we interpret them. I mean, in forensic pathology, overinterpretation is honestly just as dangerous as oversight.
Yeah, you can't just guess.
No, you can't. A major theme of our discussion today is going to be the rigorous differentiation between the cause of death, the mechanism of death, and the manner of death. We have to separate what the physical evidence definitively proves from what the circumstantial evidence merely suggests.
Right. And to set the parameters for you listening, this deep dive is a conceptual exploration of Simpson's Forensic Medicine, Chapter 11. That's pressure to the neck and asphyxia deaths.
It's a fantastic chapter.
It is. And our mission today is to build out your conceptual frameworks. We want to support your reading, reinforce pattern recognition, dissect the pathophysiology, and really nail down the medico-legal wording. But let me be perfectly clear here.
Here comes the disclaimer.
Always, this is not a regurgitation of the text, and it is absolutely not a replacement for reading the chapter yourself. Open the book, study the photographs, and use this session as a structural spine for your revision.
Because whether you are prepping for a pathology exam or you're stepping into a coroner's court for the first time, mastering these principles will change how you view a seemingly normal or, unmarked neck during an autopsy.
Yeah, we often operate under this assumption that a fatal mechanical obstruction has to leave dramatic external trauma.
And it frequently does not. That's the trap. An absence of obvious external injury does not equate to the absence of a fatal mechanism. You have to learn to look deeper.
So let's start by redefining our terms, because the nomenclature here is notoriously slippery. If we trace the word asphyxia back to its Greek etymology, it literally translates to absence of pulsation.
Right.
Which, clinically speaking, is essentially pulseless electrical activity or cardiac arrest. It's not respiratory failure.
No, the original Greek definition is entirely divorced from modern medical usage. In forensic medicine, when we use the term asphyxia, we are strictly describing an interference in the transfer of oxygen from the environment to the cells and tissues.
And that interference can be partial, resulting in hypoxia, or complete...
Resulting in anoxia. Exactly. The issue we constantly run into, particularly when dealing with legal professionals or juries, is that the term is heavily misunderstood outside of forensic practice. People hear asphyxia, and they immediately default to a visual of someone being manually strangled or choking on something.
Which necessitates a strict classification system to keep our findings objective. We have to categorize the mechanism of that oxygen interference.
Right, and today, our focus is strictly on mechanical asphyxia.
Yeah.
That is the physical interference with respiration. We are talking about the mechanical occlusion of the airways or external pressure applied to the neck or the chest.
We have to definitively separate that from non-mechanical asphyxia,
Yes.
which involves chemical interference at the cellular level, things that disrupt the electron transport chain like we see in carbon monoxide or cyanide toxicity.
And then, of course, the miscellaneous categories like drowning, where the physical interference is an environmental liquid.
Yeah.
But even within the strict boundaries of mechanical asphyxia, we have a significant amount of historical dogma to dismantle.
Oh, absolutely. The classic signs.
Yes. The most pervasive myth is the reliance on the so-called classic signs of asphyxia. For over a century, forensic pathology operated under a deeply flawed heuristic.
We are talking about the triad, or sometimes tetrad, of classical signs. So that's petechial haemorrhages in the skin of the face, conjunctivae and eyelids, then profound facial congestion and edema, severe cyanosis, and internal findings of right heart congestion with fluid blood.
Right.
I've read historical case files where pathologists documented those 4 findings and essentially closed the book, stamping mechanical asphyxiation on the death certificate without ever looking for the underlying mechanical failure.
And what's fascinating here is that this oversimplification stems largely from the work of Ambroise Tardieu. He He was a 19th century French pathologist.
Uh-huh.
Tordieu extensively documented these petechial hemorrhages, particularly in the subpleural and subpericardial spaces.
Which is why you still hear them referred to historically as Tardieu spots.
Exactly. His critical error was declaring these spots pathognomonic for suffocation. He believed they were an exclusive, definitive signature of mechanical asphyxiation.
And modern pathology has comprehensively debunked that.
Completely. Tardieu spots are not pathognomonic. You will routinely find identical petechiae in a patient who died from congestive cardiac failure or even in sudden cardiac deaths where the mechanism of dying involves a prolonged agonal period with significant venous engorgement.
So if we know that petechia appear in congestive heart failure, how do we establish a reliable conceptual framework for their presence in a forensic context? I mean, we have to look past the symptom and understand the fluid dynamics.
We do.
Let's use a metaphor. Let's treat the vascular system of the neck as a closed, pressurized circuit, like a highway. The jugular veins act as the low-pressure, thin-walled outbound drainage system, the outbound lanes.
Right.
The carotid arteries and vertebral arteries are the high-pressure, thick-walled, muscular inbound supply lines. The inbound lanes.
That differential in vessel wall structure and pressure is the absolute key to the entire mechanism. When external pressure is applied to the neck, it takes very little force, often just a couple of kilograms of pressure, to completely occlude the jugular veins.
So the outbound drainage is instantly halted. The highway is blocked.
Yes. But the carotid arteries, being deeper, heavily muscularized, and operating at systemic arterial pressures, require significantly more force to occlude. So if the applied force is enough to block the jugulars, but not enough to overcome arterial pressure.
The carotids keep pumping oxygenated blood right into the head.
Exactly. The result is a massive acute hydrostatic traffic jam. The venous capacitance vessels in the head and neck become completely engorged. The hydrostatic pressure within the capillary beds spikes exponentially.
And we see profound congestion. The deoxygenation of that static blood gives us the cyanosis, and the fluid shift causes the edema.
Ultimately, the pressure exceeds the structural integrity of the capillary walls, particularly in areas where the tissue is loose and lacks support, like the conjunctivae or the periorbital skin. The capillaries simply burst.
They extravasate red blood cells into the interstitium.
And that microscopic hemorrhage is your petechia.
So petechiae, congestion, and cyanosis are really just indicators of acutely raised intravascular pressure secondary to venous obstruction. They don't magically prove asphyxiation, they prove a mechanical venous tourniquet effect.
Perfectly stated. And as for the right heart congestion and fluid incoagulable blood, we now recognize those as entirely nonspecific postmortem changes related to the release of tissue fibrinolysis after any sudden death. They hold practically zero diagnostic value for mechanical asphyxia.
But let me challenge that from a courtroom perspective. If those capillaries require a distinct physiological timeline under massive hydrostatic pressure to rupture, what happens if the fatal mechanism is instantaneous? If we are examining a victim on the autopsy table and the face is completely unblemished, no petechiae, no congestion, pale skin, does that absence of evidence functionally exclude a compressive force to the neck?
It absolutely does not. And this is where defense arguments often try to leverage that historical dogma against modern pathology. The formation of petechiae is time-dependent.
Right.
It requires the heart to continue beating and pumping blood against that venous obstruction for a sustained period, typically tens of seconds to minutes. If the victim experiences a rapid cardiac arrest, whether from a massive vagal response, an underlying arrhythmia, or an instant structural failure, the hydrostatic pressure never has the opportunity to build.
The capillaries never reach their bursting point.
Exactly. The face remains pale. We must reiterate this constantly in our reports. The absence of petechial hemorrhages does not exclude fatal neck compression.
That conceptual pivot brings us directly into the deep physiology of neck compression, because the venous tourniquet is only one of 4 distinct physiological consequences that can occur when pressure is applied.
Let's break those down.
Okay, we've established that jugular vein obstruction causes the congestive signs. The second consequence is carotid artery obstruction, which halts cerebral perfusion and initiates a rapid ischemic cascade in the brain.
Right.
The third is direct airway closure, typically involving the larynx and the base of the tongue being forced superiorly and posteriorly, occluding the pharynx. And the fourth is the mechanical stimulation of the carotid sinus.
And to really understand how rapidly these 4 mechanisms precipitate death, we have to look at the objective data. Forensic researchers have historically analyzed filmed recordings of hangings. This is detailed in Chapter 11, specifically Table 11.2. The timeline of the agonal sequence is staggeringly fast.
How fast are we talking?
When full compression is applied, we see a rapid loss of consciousness in approximately 10 seconds due to acute cerebral ischemia. Almost concurrently, around the 10 to 15 second mark, we observe mild, generalized tonic-clonic convulsions.
And we should clarify, those convulsions aren't necessarily signs of a conscious struggle, right? We are looking at the brain reacting to acute hypoxia.
Yes, exactly. By 19 seconds, the data shows decerebrate rigidity, the profound extension of the limbs. This indicates that the ischemia has progressed from the cortex down into the deeper brainstem structures.
It's a neurological release phenomena, not a voluntary movement.
Precisely.
Ah.
Loss of overall muscle tone follows at roughly 1 minute and 17 seconds, and deep agonal respiratory movements cease completely just before the 2-minute mark.
It is a profound failure of the central nervous system driven by anoxia. But here's where it gets really interesting. We need to spend some time on the fourth consequence we mentioned, the stimulation of the carotid sinus.
Yes.
Because this is the pathway for reflex cardiac arrest, historically termed vagal inhibition. This mechanism explains those rapid deaths we talked about, where the face remains entirely pale and free of petechiae.
Right. Let's trace that neuroanatomical pathway for you listening, because understanding the exact mechanism of vagal inhibition is crucial when you are trying to explain sudden death with minimal trauma.
Okay, so the carotid sinus is a baroreceptor located at the bifurcation of the common carotid artery. It's designed to monitor systemic blood pressure. When sudden mechanical pressure strikes that sinus, like a sudden grip or a tight ligature, it artificially signals a massive hypertensive crisis.
And that afferent signal travels from the baroreceptor up the carotid sinus nerve, also known as Herring's nerve. That joins the glossopharyngeal nerve, cranial nerve 9.
Right.
That impulse terminates in the medulla oblongata, specifically integrating at the nucleus of the tractus altarius. The medulla interprets this signal as a life-threatening spike in blood pressure and triggers an immediate, overwhelming parasympathetic counterresponse.
So the efferent limb of this reflex arc travels down the vagus nerve, cranial nerve 10, permeating directly on the sinoatrial and atrioventricular nodes of the heart.
Exactly. The physiological result is profound bradycardia, a massive drop in cardiac output, and potentially instantaneous asystole.
So the heart stops before the blocked highway of venous congestion ever has a chance to develop. But as a forensic concept, relying on reflex cardiac arrest as the sole cause of death is highly controversial, isn't it? If you have an unmarked neck and a sudden death, declaring vagal inhibition feels like a diagnosis of exclusion that is incredibly difficult to prove microscopically.
It is highly controversial, and rightly so. I mean, many modern forensic pathologists are incredibly cautious about attributing death solely to an isolated baroreceptor reflex from minimal pressure.
Because it's rarely that simple.
Exactly. When you review these rapid deaths, the pathophysiology is almost certainly multifactorial. You are rarely looking at a simple mechanical switch being flipped. You have to factor in the massive endogenous catecholamine dump, the adrenaline surge that occurs during an assault.
Oh, absolutely.
If that victim has an undiagnosed channelopathy, such as long QT syndrome or Brugada syndrome, that extreme sympathetic storm combined with a sudden parasympathetic vagal shock can easily precipitate a lifelong ventricular arrhythmia.
And underlying ischemic heart disease or intoxication with sympathomimetic drugs massively lowers the threshold for a fatal dysrhythmia during the struggle, too.
Yes, it is the complex intersection of mechanical pressure, neurocardiac reflexes, and individual systemic vulnerability.
Which makes the clinical assessment of a living survivor incredibly high stakes. If you are a junior doctor receiving a patient who survived an attempted strangulation, the external presentation might be deceptively benign. They might have a few faint red marks on the neck and seem totally neurologically intact.
But the underlying physiological damage can be a ticking clock. A high index of suspicion is mandatory. You cannot discharge these patients based on a quick visual inspection. You must actively listen for hoarseness or stridor, which points to developing laryngeal edema or cartilaginous fractures.
You have to hunt for subtle petechiae, perhaps isolated to the conjunctivae, the oral mucosa, or behind the ears. That proves a significant venous pressure spike occurred.
And if there is a history of incontinence, you are dealing with a profound anoxic loss of consciousness, not just a momentary struggle.
And the vascular imaging is non-negotiable here. If that compressive force was sufficient to occlude the carotid artery, the shearing forces on the vessel wall can cause an intimal tear.
That patient is at severe risk for a carotid artery dissection. They might look fine in the emergency department, but throw a massive thromboembolic stroke 48 hours later. A thorough ENT review and comprehensive neurological and vascular monitoring are absolute baseline protocols.
That difficulty in interpreting the exact timeline and force of compression becomes even more complex when we look at the dynamic, violent nature of manual strangulation. When the compressive force isn't a static ligature, but a human hand or forearm, the forensic interpretation of the resulting marks is fraught with variables.
In manual strangulation, we typically look for specific clusters of contusions and abrasions. Fingertip pressure often leaves discoid or oval bruises, roughly 1 to 2 centimeters in diameter. Fingernail scratches present as linear, crescentic, or excoriated skin breaches.
Crucially, these scratches might belong to the assailant, or they might be self-inflicted by the victim desperately trying to pry the assailant's hands away from their neck.
But we have to abandon the idea that the skin acts as an accurate, high-fidelity canvas for recording force. You cannot examine a neck and confidently state the assailant was left-handed, approached from behind, and applied pressure primarily with the thumb.
Right, because manual strangulation is a violently dynamic event. The assailant's hands slip due to sweat or blood. The victim violently thrashes, twisting the anatomical structures of the neck under the grip. The grip is repeatedly lost and reestablished.
There is a historical case detailed in the text that perfectly illustrates the danger of overinterpreting external marks: the Barleycorn Public House murder.
Oh, this is a fascinating one. A pub licensee was found dead with classic signs of manual strangulation bruises, scratches, and a fractured thyroid cartilage. A suspect was arrested and provided a full confession, specifically stating he strangled her with his right hand.
However, the suspect had a severe anatomical deformity. He was missing the distal phalanges of his right hand.
And the defense retained Sir Bernard Spilsbury, who was essentially the preeminent pathologist of the era. Spilsbury testified that based strictly on the oval fingertip contusions on the victim's skin, a man missing his fingertips could not possibly have inflicted those specific marks.
Based heavily on that supposedly unassailable forensic interpretation of the skin, the suspect was acquitted.
And years later, secure from further prosecution, that same man confessed to the murder again, providing details only the killer could know.
Spilsbury's error was treating dynamic, shifting soft tissue as a static mold. Bruises diffuse along fascial planes. The angle of compression changes. You simply cannot reverse engineer the exact anatomy of an assailant's hand from the size and shape of a contusion on the neck.
So if the external skin is that deceptive, the burden of proof shifts entirely to the internal dissection. The forensic pathologist must perform a meticulous, layer-by-layer examination of the strap muscles, the thyroid cartilage, the cricoid ring, and the hyoid bone.
And this introduces a critical variable: the victim's age. The anatomical resilience of the neck changes drastically over a lifespan.
How so?
In youth, the hyoid bone and the laryngeal cartilages are predominantly cartilaginous and highly flexible. They can withstand significant deformation without fracturing. A young adult can be fatally strangled with virtually no skeletal damage to the neck.
But as we age, those structures undergo progressive ossification and calcification.
Exactly. They become rigid and brittle. Consequently, an elderly victim subjected to even moderate neck compression is highly likely to sustain fractures to the greater horns of the hyoid or the superior horns of the thyroid cartilage.
But uncovering those fractures or identifying true hemorrhage within the deep strap muscles requires absolute procedural discipline. If we don't follow the correct autopsy protocols, we risk creating evidence that isn't there. Which brings us to a foundational medico-legal trap: the Prinsloo-Gordon artifact.
To understand the artifact, you must understand the post-mortem venous anatomy of the neck. The neck is rich in loose areolar tissue and a massive venous plexus. After death, blood remains fluid in these vessels.
Right.
If a pathologist simply makes their initial incision into the neck while the head and torso are still intact, the hydrostatic pressure of the settling blood causes it to leak out of the severed vessels and pool in the fascial planes, particularly in the retropharyngeal space and behind the larynx.
And to the untrained eye, or an undisciplined pathologist, that pooled, leaked blood looks exactly like a traumatic antemortem bruise. This exact misinterpretation had fatal consequences in the 1929 case of Sidney Fox.
Yes.
Fox was accused of strangling his mother in a hotel room. Sir Bernard Spilsbury, whose track record we are certainly scrutinizing today, examined the exhumed remains. He found no external neck trauma, but upon dissecting the neck, he claimed to find a distinct bruise in the soft tissues behind the larynx. He declared manual strangulation as the cause of death.
When defense pathologists reviewed the preserved larynx, the alleged bruise was absent. They correctly argued that Spilsbury had likely misinterpreted post-mortem venous pooling, what we now call the Prinsloo-Gordon artifact, as antemortem trauma.
And Spilsbury defended his findings by claiming he had simply cut the bruise away during his examination. In an era before high-resolution forensic photography and mandatory histological sectioning, his word was taken as gospel. Sidney Fox was convicted and hanged based on a phantom injury.
It's a sobering reminder.
But hold on, if we must drain the vasculature to prevent this artifact, aren't we risking the destruction of other subtle signs during the evisceration process? What is the modern standard for a bloodless neck dissection to ensure the findings are unimpeachable in court?
The standard protocol is designed precisely to protect the integrity of the neck. The pathologist must completely depressurize the venous system before the neck is touched. This means opening the cranial vault and removing the brain first, which drains the superior venous sinuses.
Okay, brain first.
Then the thorax and abdomen are opened, and the thoracic organs are removed, effectively draining the superior vena cava and the lower jugular system.
So you're draining it from the bottom up, essentially.
Exactly. Only after the neck is entirely exsanguinated does the pathologist perform a delicate, in situ, layer-by-layer dissection of the anterior neck. Any suspected hemorrhage must be photographed in situ and submitted for histological analysis.
To confirm the presence of extravasated red blood cells within the tissue matrix, proving it was an antemortem injury, not postmortem pooling.
Precisely. That level of meticulous sequential dissection is equally vital when we shift from manual strangulation to ligature injuries. We need to clearly differentiate between the mechanics of ligature strangulation and the mechanics of hanging.
Right, because while both utilize a constricting band, the physical forces and the resulting pathological patterns are distinctly different.
The differentiation rests entirely on the source of the constricting force. In ligature strangulation, the constricting band is tightened by a force independent of the victim's body weight. This is typically a homicidal act where an assailant applies tension to a cord, belt, or wire.
It can occasionally be accidental, such as a scarf caught in rotating machinery, but the key is that external tension drives the compression.
Yes. In hanging, however, the ligature is tightened exclusively by the gravitational drag of the victim's own body weight against a fixed suspension point.
And we must dispel the misconception that hanging requires the victim to be suspended in midair. Full suspension is actually less common than partial suspension.
Much less common.
A victim can succumb to hanging while sitting, kneeling, or even prone on the floor. The weight of the head alone, which is roughly 4 to 5 kilograms, is more than sufficient to occlude the jugular veins and carotid arteries if the neck is positioned against a ligature.
When we examine the body, we are looking for specific pattern divergences on the skin. In ligature strangulation, because the force is typically applied dynamically from behind or the side, the resulting ligature mark is usually horizontal and often completely encircles the neck on a single plane.
And the skin beneath the ligature is violently abraded. As that abraded skin loses moisture post-mortem, it undergoes a drying process.
It forms a hard, dark brown, leathery trench that we refer to as a parchmented mark.
In hanging, the vector of force is entirely different. Gravity pulls the body downwards while the fixed point pulls upwards. Therefore, the ligature mark in a hanging typically shows a distinct discontinuity.
Right.
The mark will course upward, following the angle of the jaw, and rise to a peak, an inverted V shape, pointing directly toward the point of suspension, which is often located behind the ear or at the occiput. The mark rarely encircles the entire neck evenly because the head tilts away from the knot, creating an area of spared skin.
But we must be exceptionally careful not to overstate what the pathology can tell us. Pattern recognition is essential, but it has hard limits. The pathology of a hanging is frequently entirely neutral.
What do you mean by neutral in this context?
I mean that while the autopsy can definitively confirm that the physiological mechanism of death was hanging, it cannot always tell you the manner of death. The internal and external signs of a suicidal hanging can be utterly indistinguishable from a homicidal hanging where an unconscious victim was placed into a noose to simulate suicide.
So the physical pathology simply says, a ligature was applied and gravity tightened it.
That's all it says.
Which perfectly frames the profound medico-legal complexities of the Guilfoyle case. In this case, a heavily pregnant woman was found hanging in her garage. Her husband was ultimately convicted of murder, with the prosecution alleging he had incapacitated her, staged the hanging, and fabricated suicide notes.
And the Guilfoyle case is a masterclass in the limits of our field. The defense pathologists correctly argued that the autopsy findings were neutral. There was a single rising ligature mark consistent with suspension. There were no defensive wounds, no signs of a prior manual struggle, and no overwhelming toxicology.
The physical evidence did not definitively point to homicide.
No, it didn't. The Crown's case had to rely heavily on circumstantial evidence, the complexity of the knot, the position of the stepladder, and whether a heavily pregnant woman could physically manipulate the scene as found.
The terrifying postscript to that case is that years after the conviction, hidden diaries were discovered revealing the victim's long-standing severe suicidal ideation. It threw the safety of the entire conviction into doubt.
And it serves as a stark reminder. Pathology cannot solve the case in a vacuum. A forensic pathologist must integrate their anatomical findings with scene reconstruction, environmental context, and forensic toxicology. You cannot determine the manner of death by staring at a ligature mark alone.
I also want to clarify a common misconception regarding the internal trauma of hangings. When people think of hanging, they often think of the historical judicial long drop executions.
Oh, right.
Those were specifically calculated to cause catastrophic structural failure. Massive cervical spine fractures, typically at the C2, C3 level, often termed the hangman's fracture, along with complete transection of the spinal cord.
In typical suicidal or accidental hangings, where the drop is minimal or the suspension is partial, we rarely see significant trauma to the cervical spine or the deep laryngeal structures. The mechanism of death is hypoxic ischemia from vascular occlusion, not traumatic spinal shock.
Before we move off ligatures, we must briefly address the criteria for autoerotic asphyxia. These are deeply tragic, accidental deaths occurring during solitary sexual activity where transient hypoxia is utilized to heighten arousal.
The forensic classification of autoerotic asphyxia requires a strict set of criteria to differentiate it from suicide. It must be a solitary activity occurring in a private, secure location. The scene frequently involves complex ligature setups, mirrors, padding to prevent visible marks, and specific props.
And the death is invariably the result of a catastrophic failure in the individual's fail-safe mechanism or a loss of consciousness before they can release the tension.
But the defining paramount feature is the absolute absence of suicidal intent. The environmental and physical evidence must clearly indicate the individual fully intended to survive the encounter.
Let's transition our focus away from the neck. Section 5 deals with airway occlusion, the silent deaths. We need to distinctly separate the mechanisms of choking, smothering, and suffocation. Clinically and legally, they are entirely different entities.
Very different. Choking refers to an internal mechanical blockage of the airway, typically below the level of the epiglottis, by a foreign body. Suffocation describes a death resulting from an oxygen-depleted environment, such as being trapped in a sealed container or displacing oxygen with an inert gas.
And smothering is the external mechanical occlusion of the respiratory orifices, the mouth and the nose.
Let's examine choking through the lens of a specific, terrifying clinical presentation known as the café coronary. This typically occurs when an individual aspirates a massive, poorly chewed bolus of food, frequently meat, which completely impacts and occludes the laryngeal inlet.
Why does it mimic a massive myocardial infarction so perfectly? The victim doesn't engage in the dramatic, noisy struggle we usually associate with choking. They don't wheeze, they can't cough, and they can't speak.
They often suddenly clutch their chest, turn cyanotic, and collapse in sudden cardiac arrest.
It mimics an MI because of the profound neuroreflexive cascade we discussed earlier. Yes, there is a total mechanical airway block causing rapid hypoxia, but the sudden, massive impaction of the larynx also triggers an overwhelming vagal response.
Exactly. The afferent signals from the superior laryngeal nerve flood the medulla, triggering immediate, profound efferent vagal bradycardia and asystole. The heart stops almost concurrently with the airway occlusion.
To bystanders, it looks exactly like a sudden cardiac death. The true mechanical cause is only revealed on the autopsy table when the pathologist retracts the tongue and discovers the impacted bolus blocking the glottis.
But while choking presents a clear internal finding, smothering presents a true forensic nightmare. Imagine a scenario where a plastic bag is placed over the head of an intoxicated individual, or a soft feather pillow is pressed firmly over the face of an elderly bed-bound patient.
It is a diagnostic nightmare because smothering with a soft, yielding object leaves virtually no macroscopic forensic signature. The soft object diffuses the applied pressure evenly across the facial contours.
There are no localized abrasions, no contusions from fingernails, and frequently absolutely no classical asphyxial signs. Because the jugular veins are not compressed, you do not get the venous tourniquet effect.
So there is no massive hydrostatic pressure spike, and therefore no petechiae.
The victim simply depletes the available oxygen and quietly slips into anoxic cardiac arrest. If an assailant removes the plastic bag or the pillow before emergency services arrive, a standard autopsy might reveal absolutely nothing to indicate a homicide.
In a scenario where the macroscopic evidence is entirely absent, how does a pathologist proceed? Where do you look for the proof of a fatal mechanism?
You must elevate the magnification of your examination. The autopsy must be meticulously slow. You reflect the facial skin to examine the deep subcutaneous tissues for the faintest evidence of pressure pallor or microscopic contusions.
You must perform an exhaustive intraoral examination. When a pillow is pressed against the mouth, the lips are forced back against the hard, unyielding structures of the teeth.
You are hunting for millimeter-sized mucosal lacerations on the inner aspect of the lips, or microscopic tearing of the lingual or labial frenulum.
Furthermore, the investigation heavily relies on the scene. The pillow must be retained and subjected to advanced forensic serology to identify the victim's saliva, buccal epithelial cells, or the assailant's DNA transferred during the struggle. In cases of smothering, the autopsy is merely the beginning of the investigation.
Which perfectly sets up our final major category. In Section 6, we move from the occlusion of the face and neck to the mechanical restriction of the torso. We are talking about mechanical asphyxia via chest and abdominal compression.
Simply put, when the chest cannot physically expand, the lungs cannot ventilate.
The overarching term for this is traumatic or crush asphyxia, and the pathophysiology is both dramatic and visually striking. When immense crushing external pressure is applied to the thoracic cage and the abdomen, it physically pins the rib cage and immobilizes the diaphragm.
But the respiratory failure is only half of the equation, right?
Yes. That massive external pressure violently squeezes the blood out of the compressible right side of the heart and the major veins of the chest. Because the venous system of the head and neck is largely valveless, that massive volume of blood is forced retrogradely, violently back up into the head.
It creates an instantaneous catastrophic spike in hydrostatic pressure within the cranium and facial tissues.
Precisely. And the physical manifestations are undeniable. You see gross, intense, dark, purple cyanotic congestion of the entire head, neck, and upper thorax. The capillary beds rupture so extensively that you don't just see isolated petechiae, you see massive confluent hemorrhages. The victim appears to have been dyed deep purple from the clavicles upward.
We have tragic historical precedents that demonstrate the horrific speed of this mechanism. During the Bethnal Green II disaster in 1943, civilians seeking shelter from an air raid rushed a dark stairwell. A single person tripped, initiating a catastrophic pileup. 173 people were crushed.
And the eminent pathologist Keith Simpson, who authored the foundational texts of our field, examined the victims. He noted that the pathological signs of crush asphyxia were so extreme and profound that death must have overtaken the victims in a matter of seconds, not minutes. The intrathoracic pressure was so great that it mechanically halted cardiac function almost instantly.
And of course, the Hillsborough Stadium disaster in 1989, where 96 individuals were unlawfully killed in a horrific crowd crush. The physics of the crowd acted as a massive fluid dynamic, generating thousands of pounds of pressure that physically compressed the victims' thoracic cages, making inspiration anatomically impossible.
A far less visually dramatic but equally fatal variation of this mechanism is positional asphyxia. This occurs when an individual's body is trapped or wedged in an awkward anatomical posture that mechanically restricts the movement of the diaphragm or obstructs the airway.
Imagine an intoxicated individual who falls and becomes wedged headfirst in a narrow gap between a bed and a wall, with their cervical spine hyperflexed, pinning their chin tightly to their sternum.
Because it lacks the massive external force of crush asphyxia, positional asphyxia requires strict diagnostic criteria to satisfy a coroner. Box 11.7 in the test outlines these clearly. First, the body must be found in a confined, abnormal position that objectively restricts the mechanics of breathing.
Second, the evidence must show they placed themselves in that position or fell into it without the intervention of an assailant.
Third, there must be a clear reason why they could not extricate themselves from this lethal position. This is almost always due to extreme central nervous system depression, from severe alcohol or drug intoxication, a traumatic head injury, or a severe neurodegenerative disease.
And finally, the autopsy must exclude any other internal obstruction, toxicological overdose, or natural disease that could independently explain the death.
Which logically brings us to one of the most highly scrutinized, medically complex, and legally volatile areas of modern forensic medicine: restraint-related asphyxia, particularly deaths occurring during law enforcement interventions.
Yes, when an individual is placed in a prone, that is face-down position, often with their arms restrained behind their back and pressure applied to the torso to maintain control, the mechanical ability of the chest wall and diaphragm to expand is inherently compromised.
And as medical professionals, we must approach this topic with absolute scientific neutrality and clinical rigor. These cases are never simple mechanical equations.
When we look at the forensic consensus, what are the physiological variables compounding the prone restraint?
The forensic consensus is that these tragic deaths almost never involve the mechanical restriction of the prone position in a vacuum. They invariably occur against a chaotic, highly demanding physiological backdrop. You are typically evaluating an individual who has been engaged in an intense, prolonged, violent physical exertion.
Which rapidly depletes cellular oxygen and generates massive amounts of lactic acid.
Exactly, pushing the patient into a state of severe metabolic acidosis. To compensate for the acidosis, the respiratory drive demands deep, rapid ventilations, precisely when the chest wall is being mechanically restricted.
Furthermore, you almost always have a massive toxicological burden. These individuals are frequently suffering from severe intoxication with sympathomimetic drugs such as cocaine or methamphetamine, or experiencing the profound autonomic dysfunction associated with excited delirium syndrome.
Exactly. These drugs initiate a massive catecholamine storm. The heart is being whipped by adrenaline, demanding enormous amounts of oxygen, while simultaneously facing the mechanical hypoxia of the restraint and the rising acidity of the blood. The combination of hypoxia, metabolic acidosis, and catecholamine toxicity creates a highly arrhythmogenic environment.
The heart is primed for a lethal ventricular dysrhythmia.
When a sudden death occurs in this complex matrix, isolating the exact percentage of physiological blame, determining exactly how much the prone position contributed versus the methamphetamine toxicity versus the extreme exertion, is one of the most mathematically and pathologically difficult challenges we face.
It requires a rigorous, objective, unbiased, and highly disciplined analysis of the timeline, the restraint mechanics, and the microscopic pathology. As we stated at the very beginning of the session, pathology must speak only to what the anatomical and physiological evidence definitively proves, and nothing more. Overinterpretation based on assumptions is a failure of the science.
Okay.
Perfectly said. That brings us to the end of our deep conceptual dive into Chapter 11. But before we finish, let's run through some rapid-fire clinical scenarios to lock in these frameworks. I will throw out a scenario based on what we've discussed, pause for you at home to lock in your clinical reasoning, and then the expert will break down the answer and tell you where to refine your reading in the text. Ready?
Let's do it.
Question 1. You are examining a victim on the table. You observe a horizontal, dark brown, parchmented band completely encircling the neck on a single plane. Petechial haemorrhages are floridly present in the conjunctivae above the mark. Based on the force vectors, is this presentation most consistent with a suicidal hanging or homicidal ligature strangulation?
The clinical presentation is highly indicative of ligature strangulation. The key discriminator is the horizontal, completely encircling nature of the parchmented band. In hanging, the force vector of gravity typically creates a discontinuity or an inverted V peaking at the suspension point. To consolidate this, revisit the distinct subsections titled Ligature Strangulation versus Hanging.
Question 2. You are defending your autopsy report in court. The opposing counsel suggests that the presence of Tardieu spots petechiae localized on the visceral pleura and pericardium is irrefutable, pathognomonic proof of death by mechanical suffocation. True or false?
False. You must vehemently correct the court on this historical myth. Tardieu spots are not pathognomonic. They merely indicate acutely raised venous pressure and capillary rupture, which is routinely observed in non-asphyxial deaths, notably congestive heart failure. Review the pathophysiology of capillary dynamics under the section Phases and Signs of Asphyxia.
Question 3. A junior pathologist dissects a neck by immediately making a Y incision and reflecting the skin. Deep in the loose retropharyngeal soft tissue behind the larynx, they find a pool of clotted blood and document it as an antemortem contusion from manual strangulation. However, they fail to eviscerate the brain and thoracic organs first. What specific artifact must you heavily suspect has compromised the examination?
You must heavily suspect the Prinsloo-Gordon artifact, The failure to depressurize and drain the superior vena cava and jugular venous plexus allowed static post-mortem blood to leak into the fascial planes upon incision, mimicking traumatic hemorrhage. You will find the mechanics of this discussed under strangulation and specifically detailed in Box 11.4 regarding the Sidney Fox case.
Question 4. An elderly gentleman collapses completely silently while eating a large steak at a restaurant. He exhibits no coughing, no wheezing, and grasps his chest before entering rapid cardiac arrest. Paramedics treat it as a myocardial infarction, but the autopsy reveals a large, unchewed bolus of meat completely occluding the laryngeal inlet. What is the specific forensic and clinical term for this phenomenon?
This is a textbook cafe coronary. The total mechanical occlusion of the airway, often combined with a profound vagal reflex triggered by the impaction, leads to sudden, silent collapse, mimicking a massive MI. Revisit this specific clinical presentation under obstruction or occlusion of the airways.
Question 5. Let's trace the neuroanatomy. During a sudden dynamic struggle, transient but firm pressure is applied to the bifurcation of the common carotid artery. This pressure triggers an overwhelming parasympathetic reflex, resulting in profound bradycardia and sudden asystole before any venous congestion can develop. Which specific anatomical structure was stimulated, and via which cranial nerve does the efferent signal reach the heart?
The mechanical pressure stimulated the carotid sinus baroreceptor. The efferent parasympathetic signal that ultimately arrests the sinoatrial node travels via the vagus nerve, cranial nerve 10. This entire neurocardiac reflex arc and the forensic controversy surrounding it is detailed in Box 11.2 under vagal inhibition.
Excellent. Thank you all for dedicating your time to this deep dive. As we close out the session, we want to leave you with a final provocative clinical thought to mull over as you transition back to the wards or the lab.
We spent significant time analyzing how the progressive calcification and ossification of the hyoid bone and laryngeal cartilages make an elderly neck highly susceptible to structural fracture during compression. But flip that demographic paradigm. Consider this in your future practice. How might the resilient, highly cartilaginous flexibility of a young child's or toddler's neck entirely mask a fatal, compressive homicidal force?
It's a chilling thought.
If an elderly neck breaks easily, leaving undeniable internal anatomical evidence, and a child's neck bends without breaking, leaving virtually nothing, how does that reality force you to shift the weight of your investigative evidence away from the macroscopic autopsy table and back toward the microscopic tissue environment, the subtle scene indicators, and the circumstantial timeline?
The vital concept to ponder the next time you are faced with an unmarked neck and an unexplained death. Thank you again for taking this deep dive with us. Open up Simpson's Chapter 11, apply these physiological frameworks to the text, and we will see you next time.